we're a little after, so that's fine. I'm delighted that you guys we're able to give you some refreshments this morning, so feel free to get up and help yourselves. So a rare thing, and enjoy it while you can. But great pleasure, everyone, to welcome you to this, the final official IAS 2017 press briefing. Last but certainly not least, I think when you see what our focus is today, and indeed it's called Real World Solutions for Fighting HIV Among Young People, and I was lucky to be in Alexandra Calme's talk now, and a very poignant slide about, and I'm sure Yogan may allude to this, shown at this conference of the adolescent cascade in my own country. And that makes me want to get straight back on an aeroplane and go back to South Africa to see what we can do to get that corrected. And there's much work to be done around the world in terms of adolescents, whether they're in key populations or indeed in sub-Saharan Africa. We have to reach them. We have to ensure they can stay on treatment for the rest of their lives. Very important, aside from all the prevention issues that we know are so important. So thank you, everyone, for being here. If you don't know this yet, but I'm going to say it, I'm Linda Gale Becker I'm the president of the International AIDS Society. It's been a great pleasure to see you every day this week, and I just want to take a moment to say you guys have been extraordinary. The quality of the data the reports going out is such a key part of what we try to do through these conferences. We're very dependent on your expertise, your professionalism, and you have been superb, and I think we should give you a clap. So we've had almost, more than 400 of your colleagues here at this conference today. Please keep coming back, because we can keep talking to ourselves, but the idea is that we really, really get this out to the world at large. This is a global pandemic. It impacts and involves every single citizen in the world today. So thank you for doing that. This briefing, just to say, is live streamed on the IAS virtual conference page. Hello, everyone. Internationally, it's wonderful to have you. And we are so glad to get our fourth member of the panel. And we know there were metro constraints today. So she hasn't been drinking coffee outside. I know she's been struggling to get here. So thank you for being here on time, my darling. We are calling this briefing Leaders in Conversation, Real-World Solutions for Fighting HIV Among Young People. I'm pleased to have these experts here today to discuss the topic, because as the world's largest open gathering of HIV scientists, we know that our work provides the foundation for the global response. Too often, as I've already mentioned, young people are left behind in that response, and that even in terms of the data we have. So often the data we collect leaves this very important population out. Unless we ask the right questions and until we fully grasp the unique challenges young people face, implementers will continue to make errors. They will continue to design prevention and treatment plans with their adult mind in place, and as a result, we will continue to leave young people out. While the world has made great strides in reducing impact of HIV overall, we know this population is still heavily being left behind, and there are many gaps. So UNAIDS released new data for 2016. AIDS-related illnesses are still the second leading cause of death in fact, HIV remains our leading cause of death on our continent, but globally a second leading cause amongst adolescents. And of course, new infections amongst young women are 44% higher than they are among young men. We must work with urgency to do a better job of reaching young people with the HIV services they need. And today, we're going to hear from 4 experts who will share their experience and their perspectives on how best to speed up progress amongst youth. Before we hear from them, I'd like to briefly draw your attention that we have shown some important studies here in Paris One is a study I actually co-authored very happily. I had nothing to do with its selection, I hasten to add, which examined a successful community-based HIV counseling and testing program among adolescent girls and young women in South Africa. And we positioned it as really, this is ripe, we think, for other biomedical prevention interventions. And we are really, I think, in South Africa, grappling with the idea, and you have Yogan here to talk to about PrEP, when and how in that population. Another study in 6 African countries examined the benefits of multi-month prescriptions of HIV treatment for adolescents, and that, of course, is important. How do we make treatment simpler and easier? We also heard the results of an analysis of adolescent treatment services in 23 sub-Saharan African countries, which has important implications for our standards of care. And finally, an important evaluation took a close look at the cost effectiveness of providing PrEP to young men versus young women in South Africa to inform future PrEP implementation efforts. So all important questions that as we try to think about our combination approach to this population. So, very happy now to introduce our speakers. To begin with, Shanine Masanga, thank you for being here. A very, very impressive person. Shanine is a youth ambassador from Zimbabwe, where she advocates for communities to support youth-led prevention and counseling initiatives. So I'll hand over now to Shanine for a few remarks.
Thank you very much, Linda. And hi, everyone. As you've all heard, that I'm Shannon Mushonga from Zimbabwe, working under the Organization of Africa AIDS Swandiri, and also I'm a community adolescent treatment supporter and as well a youth champion for differentiated care. And I'm very sorry for being late. I was kind of lost. It is a great opportunity for me to be amongst you, and I think you all want to know more about me, and you've heard more about me, and you really want to dig down deep. But as well, I would like to take this opportunity that you can ask whatever you want and know whatever you want from me, and I'll be gladly to answer your questions again.
Thank you, Shanine. So we'll come back to that question and answer session in a moment, but thank you again for being here. Our next speaker is a good old friend of mine and a colleague, and a very respected colleague at that. Juergen Palais has the unbelievable task of leading the charge for HIV, TB, and related maternal, child, and women's health programs in South Africa. And as you know, we do have, unfortunately, a huge burden of HIV in our country, as well as TB. Yogan is known to this audience, has a strong record of championing and partnering with community at large, but also, very importantly, young people. And I'm so excited he's going to tell you what the South African government is doing, which I'm very proud of.
Thank you very much, and good morning, everyone. Linda Gale is right, we are old, both of us. I think the first point to make is that, the youth are not a homogeneous group, and I think, our programming needs to reflect that. So we have youth in school, we have youth out of school, which presents a different set of challenges. We have youth in colleges who have different demography to youth in universities, and we have young people in the workplace. So we need to obviously deal with programming that relates to the experiences and needs of the youth and wherever they are in that spectrum. In South Africa, we have in total just over 5,000 new infections of HIV per week in the general population. And of those, just under 2,000 are in young women, 15 to 24 years of age. So, even if you leave the young men out, in young women, there's a fairly significant number of new infections every week. So what have we done? This has been of concern to us for a while. And the first thing was to figure out, how are young people being infected? And I think the previously shown phylogenetic study gave us some good ideas about how young people get infected. And it turns out in a triangle, you will find a group of slightly older young women, average age about 28, who are infected, not on treatment. They have sexual relations with their peers almost, somewhere between 29, 30 years of age, young men. who then have sexual relations with the very young women, average age 18. And, that kind of triangle keeps moving. So clearly what we need to do is we can't work with just one of those three parts of the triangle. We'll have to work with all three parts of the triangle to break the transmission. In June last year, the Deputy President of the country, Cyril Ramaphosa, launched a campaign with young people, led by young people, focusing on young people, called the She Conquers campaign. And this name was given after a competition by a young person from one of our provinces, the name of the campaign. And it has 5 objectives. And the reason we have 5 objectives and not just HIV is because we think that HIV is a social disease as much as it's a medical and biomedical disease. So the first, of course, is to reduce new infections in this cohort of 15 to 24-year-olds. The second is to reduce unwanted and unplanned pregnancies, because we have a fairly significant burden of teenage pregnancies as well. The third is to keep young girls in school, because we know keeping girls in school until they matriculate protects them from a number of social ills and also makes them better able to engage with the economy, go to university, etc., post-school. The fourth is to reduce sexual and gender-based violence, because it's really reaching epidemic proportions in some parts of our country. And we know that this is another way people get infected with HIV, get pregnant, etc. And finally, to create economic opportunities for young people, because clearly without economic opportunities, young people left to their own devices will do things that will put them at risk for HIV and all kinds of other challenges, both medical and non-medical. So this is the campaign. We have isolated 22 sub-districts in the country with the highest prevalence of HIV in young people, together with teenage pregnancies. And we are doing a very granular level data analysis at that level to have a very specific and focused campaign, depending on the level of vulnerability and risk of young people in those communities. And the interventions are then targeted to their specific vulnerabilities and essentially to make them more resilient to not only HIV, but to their life circumstances. Thank you, Linda.
Thanks, Yogan. And I'm sure Yogan will also invite questions on that campaign afterwards. So our next speaker is someone also who needs no introduction. Kate is well known to these conferences and a much valued person in our community. She's head of community rights and gender at the Global Fund and also head of the Global Fund's Civil Society Hub. She is a leader in global health and development with a long history of working directly with communities at high risk and those living with HIV. So Kate, your comments.
Thanks so much. I mean, from a funding perspective, it's important to stress that despite the evidence we have of disproportionate impact of HIV on adolescents and young people, particularly adolescent girls and young women in parts of Africa and those from key populations, the investment in programs, but also in their leadership and engagement and specific services that meet their needs is hugely inadequate still. So within the new Global Fund strategy, from 2017 to 22, we've put a particular emphasis on some of these areas that need to be addressed. So really looking at meaningful engagement and leadership of young people, but also particularly looking at scaling up gender-responsive HIV and sexual and reproductive health programs, and with a particular focus in sub-Saharan Africa on 13 countries. So in terms of some of the specific things that we're doing at the Global Fund to really ensure that we're actually addressing some of these massive gaps, as I mentioned, we're really looking to ensure that funding and technical support for youth-led programming and approaches that work is there. So really, we're trying to, through our funding, our programs, fund programs that mobilize demand for service uptake amongst key populations, young key populations, I should say. We're also funding programs that support greater adherence and retention in care by adolescents and youth living with HIV. So really, sort of supporting the youth to actually do that work themselves. We're also supporting programs that analyse and address human rights-related barriers to services for young people. So supporting, for instance, legal environment assessments and reforms through some of our regional grants, and also programs, importantly, that develop the kinds of structural barriers that Yogan was talking about, gender-based violence, keeping girls in school, and so on. Then, importantly, we're also really focusing on how we can support young people to meaningfully engage in national decision-making processes. So, and those processes don't, go beyond just Global Fund specific, but national strategic plan development, country dialogues, and so on. So, we have a small grants program now for innovative, locally appropriate work to support mobilisation of adolescent girls and young women in the 13 countries where we really have a focus in East and Southern Africa. We're also focusing on how we can tailor support for youth members on Global Fund governance structures, so the country coordinating mechanisms at country level and the board. So, and that includes the development and rollout of a tool to support youth in engaging, and I know it was piloted in Zimbabwe, and with some quite positive results in terms of youth engagement, young people's engagement in the CCM. And then also partnering with young key population networks throughout the grant cycle, so the specific partnership we've had with Youth Lead, which is a network of young key populations, to really support them to capacitate their representatives at country level, including in doing things like monitoring service quality for services provided to young people. And then collaboration also with the number of different actors is absolutely essential. We are at Global Fund, is a partnership, and we work across partnerships. So strengthening the partnerships with technical agencies such as UNICEF, UNFPA, WHO, to really develop the strategic information at global and country level that's needed in terms of age and gender disaggregated data for service coverage, and making that case for more strategic investments. And also aligning and leveraging with other initiatives such as PEPFAR Dreams and, the UN Stay Free, All In, and so on. And then also looking at the issues of sustainability, I think, and long-term health financing and system strengthening more broadly. And then just very briefly, also we're currently trying to mobilise resources to scale up some of these innovative interventions through a collaborative platform that's bringing together private sector, individuals and other agencies to support a lot of the advocacy for policy change and engagement that is needed. And we also have within our funding model what we call matching funds, which are supposed to incentivize countries to prioritise programs that support gender equality and human rights. And that's one other thing that we're doing, which is, I think, important to mention, is a community rights and gender strategic initiative by which we actually fund community service providers, TA providers themselves to provide services. So we're trying to, so it could be, for instance, sex worker networks, supporting sex worker networks, human rights advocates supporting other human rights advocates, very much south-south. But within that, we're really trying to bring on, youth organisations to be providing that support south-south as well. And including young key population networks, but also, people working, more broadly on gender-related issues. So that's just a snapshot of some of the things that we're trying to do in terms of trying to move forward towards being a more responsible funder and donor that's really working with and partnering with communities and letting communities of young people actually lead the way in terms of how we program and what we program for and what we fund.
That's great to hear, Kate. And it just to say that the Adolescent Treatment Coalition, which I know has sort of yes, that you know it needs. This was very much the discussion about how to really allow people to be part of that and receive funds directly. So, our last speaker is Anna Grimsrud. She's a program specialist with the International AIDS Society. Anna is guest editor of the Differentiated Care and HIV Supplement to the Journal of the International AIDS Society and a member of the working group that produced a family's decision framework on delivering differentiated antiretroviral therapy to children, adolescents, and pregnant and breastfeeding women. Both were launched at this week at the conference. So we know a one-size-fits-all model for HIV services, pretty much along the lines of what Yogan was saying, is not going to be ideal. We do need to differentiate. And so, Anna, tell us what that means.
Great. So thanks, everybody, and I really welcome this opportunity to speak with you all today just a little bit. As Linda Gale said, we've launched some documents here in Paris, but by way of kind of some background would be that we've really made huge strides in terms of implementation of antiretroviral therapy across the world, but we still know that we need to almost double our treatment cohort. And so if we're going to double our treatment cohort, business as usual is not going to be the way we need to get there. And so most recently, when WHO has put out their guidelines in 2016 to treat all, they also started including a chapter on service delivery. So it was no longer just about who should be eligible for treatment or what drugs we should be providing. It also included how are we going to get these services to the people. And I think that's the how is really what keeps me up at night. As part of that, how the WHO started to say, look, we need to kind of consider the clinical needs and what the clients' needs are when they enter services and what they need to be retained in services. And so they started to think, you know, this public health approach has really been scaled up and we now have 19 million people on treatment, but we need to make sure that we're not just doing more of the same. So we've worked to try and make sure that the voice of the client comes through clearly, and this differentiated care approach where we provide services in ways that meet the needs and expectations of clients is out there, but also acknowledging that we operate in a scarce resource setting in many of our environments. And before this conference, we saw a lot of interest in differentiated care for adults, but accidentally and kind of without a lot of consideration, we saw that this approach wasn't being utilized for children, for adolescents, for pregnant and breastfeeding women, and for key populations. But it should be. This idea that it's maybe helpful for young people to come to the clinic all the time doesn't necessarily make sense, and we need to reconsider what works for them. And so at this week, WHO, with its PEPFAR partners, CDC, USAID, as well as the IAS, has said that adolescents and young people who are clinically stable can receive longer ART refills. Maybe 3 to 6 months of drugs can be given to a young person, to a teenager, and that's okay. And maybe clinically, they only need to be seen by a nurse or a doctor every 3 months. This idea that they need to be seen all the time with clinical care doesn't make sense if they're adhering to that treatment. But that's only going to work if they have a strong psychosocial support network in place that could be provided by the healthcare system. But when we talk to young people, we hear them say, we want to talk to someone like me. We want to talk to an HIV positive peer. That's the provider that we're going to need. And so we've launched this how-to guide for ministries and ART managers to say, you can provide services like this for adolescents, and you can do it using some models that we've seen from countries like South Africa, Malawi, Zambia, and the Zvandiri model, which I'm sure Shanine can tell us more about. And I think for me, what's been a take-home from this conference is that we had a workshop yesterday where one of the youth champions for differentiated care said, HIV lives in me, but it listens to me. And I hope we also listen to the young people living with HIV that are in the room. So I'm not going to take any more of your time. Thanks.
Thanks, Anna. Brilliant. I appreciate that. And thank you for that. I unfortunately wasn't in that session, but I'll take that to heart as well. So it's our time now for questions to the panel. As usual, if you would like to ask a question, please go to the microphone and tell us where you come from or what your institution is, and just tell us where you're directing the question. Thank you.
Hi, I'm Ed Sussman with MedPage Today. For Ms. Mushonga, of all the presentations you've just heard here, what rings true to you? What do you like? What don't you like?
Okay, thank you very much for your question. I'll start with my don't likes. Well, what I don't like usually for myself, I'll just say in general, I don't like heights. I'm afraid of heights, but I don't know how I got in the plane. Think about that. But basically, what brings through me is the passion which I had before in meeting my other peers when I was lost and when I didn't know what is happening in my body, what the virus is doing in my body. But once I met with a group of young peers and linking to my story, I just thought that my story is a small problem, but my other peers are facing more challenges than mine. So why don't I stand up strong and find a way to also help them? So from there, that's when I started to think that it might be good that I would stand up and also help my peers who are facing more challenges beyond mine. And that's when I started from there. And before there, when I was still young, I used to help people, and I used to have this courage thing to also stand up and help people. But from that same spot, I think there was a purpose for me to meet my other peers who were the same as me, so that I can stand up there and also show them that and empower them that it is not your problem, it is not your fault to be living with HIV, but there is a reason beyond that which needs to be enlightened to you to stand up for your rights and everything.
Thank you. Any other comments or questions anybody wants to ask? Maybe, again, in terms of our international listeners, I do want to just say, perhaps to Kate, how, what are some of the things you think governments could do differently to leverage the Global Fund's resources to better meet the needs of young people in their countries?
Thanks. That's a really good question. I mean, one of the things that immediately sprang to my mind is actually for governments to be willing to ensure that in schools, young people can get proper, adequate sexuality education. I think in some contexts that there's such a taboo about talking about and acknowledging young people's sexuality, and I think in some places I know there've been great steps taken, such as in South Africa, but in other places that's not happening. And I think that would be a key step in terms of broadening out the discussion, not only about young people, but sort of making it easier for, hopefully, others, service providers and others to actually have those conversations. So I think an openness to doing that would be key. But also, I mean, most people in government are of a certain age, and I think most of us are of a certain age now. And it's I think for all of us who are involved in decision making at any level, it's just recognizing that we may have a lot of knowledge in some ways, but there's so much that we don't know, and the world has changed so much since we grew up. The reality of young people's lives is so different. So it's about not, really, again, it's going back to that, that point of ensuring that there are spaces opened up and opportunities to, for two-way learning, to really understand the realities of young people's lives, because that's the only way that we're going to be able to understand and develop the programs that need to be developed. And I have to say, we don't know exactly what works. So there also has to be the willingness to take some risks in terms of trying other things out. We don't know what the perfect comprehensive package is for young people. So there have to be some risks taken and some ongoing learning that needs to be done in partnership and hand in hand with young people themselves.
Thanks, Kate.
Hi, I'm Paul Ben-Kimoun with Le Monde here in France. As you say, one-size-fits-all approach has long proved that it doesn't work or not work for everybody. But nevertheless, could you name some of the common grounds, common things for engaging with the youth, and when it give also some examples of for specific subgroups you may have identified in some settings, which kind of approach can really reach those people who are left behind for the moment?
Thank you. Is there anyone in particular you wanted to direct this to? Anna, do you want to start? And then maybe Yogan also wants to, and then of course Shanine may have some ideas. So let's do it in that order.
Great. So it's an excellent question, and it picks up on what Kate was saying, that we don't have all the solutions, but we definitely have some, and I don't think we can afford to just wait or afford to always do randomized control trials either. And I think it actually starts with asking what young people in that context want. So there's also not a copy-paste repeat approach that I would recommend, but there are some best practices. So I think from South Africa, we've learned that when we support adolescents and young people to receive their care and treatment in a group, that works really well. And that group doesn't need to consist just of people who've been on treatment for a long time and who are virally suppressed. It's beneficial to people who have been newly diagnosed or who are newly initiated on treatment to join with someone who has more treatment experience so that they can learn from them. We also see the scale up of teen clubs in a country like Malawi, where there's now almost 10,000 young people accessing their care on Saturdays, a time that's convenient, because when we've spoken to young people, they say, I don't want to miss a day of school every month to come to the clinic. I'd actually also like to do well at school and not make it so obvious that I'm not there. I'm sure Shanine can talk about her model. And then we've also seen that adolescents and young people, it's okay to give them longer supplies of drugs. If they understand how the treatment works in their body and they understand how to take their medication and have a support network in place if they need help and have an adolescent-friendly health service that they can visit even if they don't have an appointment, it's okay, and we can trust them to have 3 or 6 months of drugs that have been provided. So that's what I would start with.
Just to add to Anna, adolescent-friendly services at public health clinics are critical, which focuses also on the attitudes of health workers to young people. And that's something, we're still really grappling with. We have many instances of health workers saying to young people, you're too young to be on contraception, for example. Or why do you want an HIV test? You shouldn't be having sex, where sexual transmission is the predominant transmission route. The other is, besides the teen clubs, the use of cell phone technology, I think, is going to be quite a big issue to young people, because we know young people, well, many people like to use mobile technology these days. So just to use it as a reminder, for example, to take your meds, because we know that adherence in young people is something we're struggling with. In a cohort that we have in South Africa, only a third are adherent. And I'm sure Linda Gale has, in her experience also similar kinds of low levels of adherence, unless you provide a fair amount of support to young people. And then in terms of testing, what we found, especially at colleges and universities, they would much prefer you to go into the colleges and universities and offer testing as mobile services, rather than expecting them to come to our facilities for testing. And I think in that regard, the self-testing kits that are going to be available, on a fairly wide scale soon, is going to be potentially a game changer with young people, together with PrEP. So I think these new technologies, if introduced carefully with young people, are potentially also big game changers.
Huge. What about Zvanderi? Tell us about it.
Yeah, I would like to add on what has been said by Anna, and also, since we all know that adolescents and young people are a homogeneous group and we don't usually need a one-size-fits-all. As for Zimbabwe, we have this Africa Jandiri organization. It is a community-based organization, and there is a CATS model, which is supported there by the Ministry of Health in Zimbabwe. So as CATS, we do home and health facility visits, whereby we meet with our young peers teenagers living with HIV, because since we do that, we have noticed that more young people are afraid to go straight to the clinicians because they tell us that they are being judged of how you got HIV and you're too young to access contraceptives and sexual reproductive health. So they prefer to come to us since we live in the same road. By doing that, we also do mobile settings like social media platforms, which was said before, doing SMS reminders in case of that young peer forgets to take his or her medication, or maybe he or she might have left the phone or doesn't have a phone, because in Zimbabwe you have outreach areas. We talk to the caregivers and parents that you might give us your phone number, and also we can do SMS reminders to remind your child as you'll be by her side to support him or her in everything that she needs. And besides that, we have tools that we use when we monitor adherence and also providing support to our young people. And these tools, there are pill boxes for storing pills, and also books which explains in a broader sense of how to live a brighter future, and also a soldier game to play to young children who are partially disclosed, who don't know their statuses, till they know their statuses. And also we encourage parents to do early disclosure, and to encourage our young peers to go for HTS so that they can know their statuses. And more of it, we also work hand in hand with clinicians, and also we work hand in hand with school heads and also school teachers, so that we can disseminate information of HIV and also reach to the target of where we can fight a stigma against HIV.
Thank you, Shanine. Do you want to tell us what CAT stands for, just so that people know what that is about?
Okay, so CATS, it is the abbreviation. They are not animals. So it's community adolescent treatment supporters. These are young people, young adolescent people living with HIV from the ages of 17 to 24 years. That's the inclusion criteria. And also they are outgoing. And since we are all cats, you might be wondering that what will help us through the income financial things. We are being provided by small stipends. And from there, we are being told that you can live with it. It is a stepping stone for you to start a bridge of building your own future and getting engaged in the world out there.
So, important consideration there, not only asking young people to be involved, but actually providing some kind of income and then making sure there's a career path thereafter. So thank you very much indeed for that, Shanine. And we think we should become part of Royal Game. Definitely, these cats, they are incredibly impactful in that program, and needs to be spread around. I think we can. Are there any other questions? Yes, please.
I'm Michael Dumiak from IAVI Report. My question is addressed to Juergen, but probably the other four women on the panel, or the four women on the panel, might have some perspective on it as well. And that's on the topic of gender-based violence, since you brought it up, and its relationship and impact on transmission. I wonder if you could elaborate that on that a little bit. Are you speaking just about sexual violence, or are you talking about something other things further? And perhaps if you could point to some specific examples of effective strategies that you've seen in going against this sort of thing. Yeah.
So no, you're absolutely right. It is not just sexual violence, it's sexual and gender-based violence. So it includes physical violence, abuse, and it's largely revolves around, patriarchy, I think, is a very important contributor in our context. And the disempowerment of women. And the more economically independent women are, the more likely we are to see reductions in all forms of violence that are perpetrated against women. So in South Africa, that's one of the reasons we included it in our She Conquers campaign. We think it's very important to change gender norms. And part of that also is to work with young boys in order for them to grow up, not in a patriarchal society, but in a society of gender equity. And we have some examples in South Africa of how we're trying to do that. But notwithstanding that, we have certainly very high levels of of violence against women in South Africa. And a lot of that relates also to medical conditions like HIV, but all kinds of other things too. And we're taking it very seriously. I mean, just yesterday, there was a new coalition formed between government and civil society organizations, including the religious sector for the first time, to try and figure out how we mount a, all of government, all of society campaign around gender-based violence in South Africa. Because we think, it's really it's not a new frontier at all, because we've had, gender inequity for, I don't know, for as long as humanity probably, I don't know. But we need to kind of change gender norms, but starting in schools, including at, early childhood development centers. And unfortunately, it's a long-term project and no quick wins. The challenge is that alcohol plays a fairly big role as well in this context, certainly in the South African context. We have high levels of alcohol use and other illicit drugs, which also we think fuels the way in which men treat women in South Africa.
Okay, so I think I'm getting the signal that, thank you, Yogan, for, I think perhaps to draw that together, as we've known for a really long time, this is multi-sectoral, it needs to draw all aspects. Today you've heard how important the education piece is, the religious sector, the bringing youth groups themselves absolutely front and center into this. So, I think one of the reasons we perhaps haven't done so well in this area is that it's challenging. But boldness, I heard that word today, and I think that's really important, that we need to boldly take on this challenge. And we owe it to teenagers around the world who I think have had a raw deal. They really have. And what resonates in our minds all the time is the youth bulge that we are moving into now. We have no time to squander in this regard. So we have catch up and we have more work all coming at the same time. So I think very important that, and thank you to the team for putting this on the last day, so that it's in our minds as we leave. I want to again thank everyone, thank the panel, thank you to each one of you for the important role you play, and again, each one of you for coming, for spending the week with us here, and all the best, and we'll see you in Amsterdam, I hope. Thank you very much.